Good afternoon.
Hey, Ebony.
Good afternoon.
Angel, I always like your picture when you're not on screen. It just screams, "Don't mess with me."
Oh, thank you.
I remember when I saw it for the first time, I was like, why is she not moving? Like she's just
Yeah, I'm moving there. Trying to move away from this dog. I'm moving there. Hi, everyone. Get back.
Hello, everyone.
Hey, Jonathan. Ruby, do we have a quorum yet?
Almost. I'm waiting for two more people, two more HSAC
Okay.
members.
All right, thanks.
We have quorum now.
Okay. Hello, everyone. I'm gonna call the call to order housekeeping now. We're gonna start on number 2 with the minutes to review and approve for the approval. Are there any additions or corrections to the January 19th minutes? If so, can I get a motion?
Madam Chair,
Yes,
sorry.
ma'am. I'm sorry.
Um,
Yes, Rita.
I reviewed the minutes. The only thing that I noticed was that there's some misspelling of some names in there. Like, I think my name is spelled 2 different ways. And I think Miss Carolyn Schultz's name is not spelled correctly in a couple spots. That's the only correction that I see that needs to happen.
Okay.
Carolyn
Schultz, and who else?
And myself, so my last name is MCCO. So in some places it's O, in some places it's U.
Yeah,
And then the last part of Miss Carolyn's name, I mess it up all the time. I think it's D, not Z. SCHULT D. I think it's the spelling of her name.
Schultz, SHUTLT. Is it Z?
I
don't-
got it off the sign-in
Two
sheet,
different.
so,
It's just 2 different ways in the minutes, and I just wanted just to bring that to the attention, just in the event that somebody thinks it's a different person. That's all.
okay. And yours is,
It's
not the U.
DT. Thank you, Helen. Thank you, Sharita. Thank you, Dr. Burt.
Yeah. Okay,
Okay, so can we get a vote in the chat now?
Madam Chair, I make a motion that the minutes be approved with the corrections of the names to be amended.
Okay, is there a second?
I'll second that one.
Thank you, Helen. So be it. Moving on to number 3, the public comment period. I'm Ruby. Oh, I'm going fast. Everybody haven't finished voting. Okay, looks like minutes are approved.
Majority
Now-
vote, Madam Chair.
And you have that, Dr. Birch?
Yes, ma'am.
Okay, thank you. All right, we'll move on to number 3, public comment period. Ruby, is anyone signed up for the public comment?
Yes,
so-
Russell Pierce from Housing for New Hope.
Okay, Russ, take it away.
Thank you, Madam Chair. And I appreciate just a moment. We understandably focus our energy in these meetings on government funding sources. But I wanted to take just a moment to highlight an important privately funded resource that's had a big impact on our shared work over the last couple of years. And that's about to wind down, and that really could impact our overall work. So in summer of 2020, actually spring of 2020, just as the COVID pandemic was kind of beginning to grind, Durham was one of 4 communities chosen by the North Carolina Coalition on Homelessness with funding from Blue Cross Blue Shield's Healthy Blue initiative to run a landlord engagement pilot. And Housing for New Hope, even though it wasn't actually the landlord engagement contractor for the COC, did partner with Community Empowerment Fund. And over 100 days, with about $50,000 in funding, 8 agencies partnered together to get 49 households into housing. This was an incredible turnaround in a period where UMD was in the Marriott, then moving out of the Marriott and back to their regular quarters and then to expansion space. And it's important probably to know that this provided funding for landlord incentives that we were actually able to layer on top of the city-funded, DHF-funded landlord incentives. And if you look at the data from 2020, you'll see a spike in the June, July area. and it overlaps with when these funds were available. And it had a big impact, not just on the landlord incentive funds and getting more landlords working with us and more units open, but also barrier busting in terms of paying rental arrears off, paying extra deposit funds. And that was true for over 50% of those who participated. So then that concludes. And in winter of 2021, NCCH was looking to do a longer pilot project with similar funding, similar setup. And Durham was again chosen as one of just 4 communities with H&H in the lead. And part of why we stepped forward to do this was we understood that the landlord engagement contract would be ending in June 2021. CEF at that time was not intending to renew, and we were anticipating, with a lot of other priorities on community development's plate, that there could be a gap in terms of another RFP coming out for landlord engagement and for a partner being chosen in the community. So we stepped forward and received almost $250,000 for our community, both for some staffing and landlord incentives. And since last July, 7 agencies have done similar work as the year before, partnering with 70 households here in our community in the COC. A lot of this has been similar funding, including landlord incentives. About half of the households have received landlord incentives to the landlords that are partnering with us for about $1,000 a piece. More than half have received barrier buster funds to pay off rental arrears, averaging about $1,700 per household, paying renter's insurance that in some cases is the only barrier to somebody getting into housing, but also paying additional security deposits and sometimes part of a first month's rent to bridge the gap between moving in and when an HCV will kick in, again, averaging about $1,000. So we've really found this to be an enriching piece of work for the whole system. 70 households is not a small amount considering the number of households that are moved in any given year through the project. And we have anticipated as a community that another RFP would be coming for landlord engagement. We've had many conversations around this, had conversations, Mayor Schul brought it up last September, in fact, former Mayor Schul, of knowing that it was a key piece. And so I'm just raising this because we are going to talk later today about a number of priorities, many of which have historically been government funded. And this has been a very important bridge and impact on our system. And so we're anticipating all this funding being gone at the end of May, at which point there will be no landlord incentives available that aren't kind of buried inside specific programs, nothing generally available across the system. So I wanted to raise that and share 2 things we're doing and 1 thing I'm hoping that we can do collectively to mitigate some of this. We are partnering with NCCH through this program to bring in professional marketing help to continue to help us get sharper in the materials and the presentations that we give to landlords as we try and bring new landlords on board, and happy to share that as those materials are created. We are planning to bring Clutch Consulting Group from Houston, who is a national expert in housing location and navigation, to provide case managers, training, and others across our full system to better understand housing navigation to mitigate some of what could be happening when we lose this funding. And then the last piece is just to ask where we have opportunity is to help raise this up for the whole community as a priority. We can certainly understand everyone has a lot on their plates and a lot of priorities. I often joke, I think I've joked about this with Colin in the past, if somebody will call and say, hey, we're waiting for you to do this or that. And we've emailed and we've called, and when can we get it done? And I'll smile sometimes and say, well, the good news is that on the top 10 list, you've moved from number 48 to number 24. And so you're getting closer. But my hope is that somehow together we can look at this critical need and find a way to get this at least into the teens of the top 10 list, if not into the top 10, because a number of us are quite anxious about what happens when we lose any incentives in this extraordinarily difficult affordable housing market, if we're going to keep connecting our most vulnerable neighbors to housing. Thank you.
Okay. Thank you so much, Russ. Appreciate you.
Yeah.
We're going to be moving right along right now to number 4, Performance Management Committee Quarterly Support Report. Jonathan, it's your turn to come up.
All right, thank you, Madam Chair. Good afternoon to everyone, and it's a pleasure to be here with you today. I'm just going to give a brief report on what our committee has been up to. There are basically three main things that we have been focusing our energies on. First off, we reviewed the COC scorecard and adopted some changes to it for the spring COC evaluation. We went through that late at the end of the fall and adopted it here in January of 2022. That being said, now that we have an adopted scorecard, we are now in the middle of scoring applications for the spring COC competition. We have a panel of 4 folks that are currently reading through the applications, and we will be discussing the results of the scoring at next month's Performance Management Committee meeting. The last thing that we have been working on is an update to the benchmarks, performance benchmarks for our COC projects. The benchmarks are basically the way that we can look at the system at any time at any of the projects, whether they be street outreach, transitional housing, emergency shelter, rapid rehousing, permanent supportive housing. And we can look at them and determine whether or not they are meeting a basic standard, whether or not they are high performing. These standards were last updated in 2014. So we have started work on them beginning at the end of the fall and have continued to work on them. Originally, I was planning to present them this afternoon to give you the results from the work that we've done on them. But as the time has gotten closer to the meeting, it has become clear that a little more work needs to be done on the presentation so that we can give you the fullest clear picture here of what we're recommending and why. So the plan for that is hopefully to present that to you in full next month. So that's what we've been up to. And if there are any questions, I would be delighted to answer them.
Are there any questions for Jonathan from anyone? Well, I guess, Jonathan, no one has questions for you right at the moment on this
That is
topic.
okay.
Okay. Okay, so thank you, Jonathan, for that information. And we're going to switch up right now. We're going to be moving on to number 5, but we're going to bring on Liz Stevens right now. Liz, are you ready?
I am ready. Thank you so much for having me.
You're welcome. Go ahead, dear.
All right. Good afternoon, everyone. It's nice to see a lot of familiar faces on here. I know many of you and good to see you. I'm Liz Stevens. I'm one of the Deputy Public Health Directors at Durham County Public Health. And Colin invited me to come and speak with you all this afternoon just about some COVID updates. And as always, I'll try to answer questions that you have and leave some time for some dialogue to try to be as helpful as I can. So I'm going to share my screen and see if that wants to cooperate. Are you all able to see? Whoops. Are you able to see the presentation?
Yes, ma'am.
Okay, awesome. All right, so we've seen this before, and I'm showing it again. We continue to rely on our 3 Ws. So as everyone knows, we're moving into a new chapter in what COVID means for the community. I think at one point we all thought that COVID moving from pandemic to endemic was going to be this real clear line in the sand that we would cross over at some point. And I think it's become more apparent that that is not necessarily what it's going to look like. But in the meantime, as we continue to kind of rethink metrics and rethink what it looks like to live with COVID, we are still continuing to encourage our 3 Ws of wearing your mask, particularly in indoor settings, waiting 6 feet apart, washing your hands, and of course, vaccinations. Vaccinations are the best tool that we have to prevent severe illness from COVID-19. So I'm going to show you some brief kind of current stats. So we are thankfully on the downturn from our Omicron wave. Some of the metrics that we currently look at are our total cases that have come in the past 7 days. So you can see that's at 855. We have seen a number of additional COVID-19 deaths in the past several weeks. For the most part, those tend to be unvaccinated or partially vaccinated individuals, generally folks with other underlying comorbidities. That does continue to be the case. We also pay close attention to our 7-day moving average, and I've put it on here as a raw number of cases and also per 100,000. So our 7-day moving average has been going down over the past couple of weeks. You can see it's about a 30% decrease from last week and about 58% decrease from the week before. I'm sure many of you know about our coronavirus data hub, and I encourage you to go there regularly to get up-to-date info. As has been talked about a bit in the news and among our own city and county officials, we know that we're expecting metrics to change. We know that because of the way that Omicron behaves in terms of a real kind of quick time, transmission time, a lot of people being diagnosed as positive, but not necessarily symptomatic. A lot of people utilizing home tests to learn that they're positive as opposed to tests performed in a clinical setting. We know that the metrics that we've been relying on so far are not maybe as useful as they used to be. So we're expecting metrics to change and are awaiting that from the CDC and the state, as well as doing some brainstorming ourselves here on the local level. We might start looking just at symptomatic cases, hospitalizations, wastewater surveillance, and vaccination rates. I think, well, are you able to still hear me?
Yep.
Okay, I think the power just went out, the health department.
Oh,
So I'm gonna reshare my screen.
okay.
Thank goodness for laptops. Sorry about that.
No problem.
All right, and we're gonna go to this view if this is okay, because on my laptop, I don't know that. Don't know that I'll be able to get the big like presentation screen. Does that work for everyone to be able to see?
Can everyone see that? Does it need to be
Yeah, okay.
made larger?
Works.
All right, we're gonna keep it moving then. Thanks for your patience. So another metric that we've been paying attention to of late, and again, this may change with time, is our percent of positive labs reported. These are just a measure of labs reported electronically, mostly really just our PCR labs that are reported electronically. So again, not maybe the most reliable measure, but one that we are still paying close attention to. And it's been encouraging. If you look at the lines on this screen, Durham is the dark blue. So of all of our surrounding and kind of comparable counties in the triangle and triad area, we currently have the lowest percent positivity of all of our testing being done. And that is not necessarily because there's less testing being done. There's still quite a bit of COVID testing happening. And we've just seen since really kind of mid-January or so on this graph, you can see that percent positivity has been going down. So very encouraging. The other thing that we've been looking at all along, and again, this might become a little bit more important as we think about like the metrics that are going to best influence decision-making going forward, is hospitalization, right? So this chart shows hospitalization. The top line here is new admissions, and then number of beds, percent of beds used, and percent of ICU beds used. And this is since August of 2021. So you can see we hit our peak here on all three of those measures in January with this Omicron wave, and we've been coming down really nicely on all of those ever since. One thing that I think is really important to point out, and something that we have been doing a lot of talking about within public health, is the fact that we're still at this level that is real similar to the peak of the Delta wave as it relates to hospitalization. So I think a lot of us feel like things are so much better right now. And as we think about like relaxing some of our measures and kind of changing the ways that we're operating day to day, I think it's important that we keep it all in perspective and know that even where we are now, it feels a lot better than it was in January, but it's still sitting, pretty close to that peak that we had with Delta. So just some good perspective. So as we know, Durham has done well related to vaccinations really all along, and that is thanks to a lot of people, a lot of public health and health system staff for sure, but also many of you. I think I've really been so grateful to partner with a lot of you in making vaccines and boosters available to some of our staff and folks staying at some of our homeless service provider locations. So that continues to be really important. We are boasting pretty high vaccination rates of all of our eligible population. Those over 5, 74% are vaccinated. And that number just goes up as we look at 12 and up, 18 and up, and 65 and up. We still have some work to do related to boosters. You can see over here our booster percentages. And that is certainly an area that still warrants our attention and is something that I think we are thinking about at the local level about how to maybe get out and reach those people who haven't come back looking for boosters. And there's some work being done at the state level as well, just making sure that those are being made available to folks in an equitable way. Of course, we know according to the CDC, we are still considered in the high transmission zone. But again, like I mentioned earlier, with the metrics changing, that may change too. So vaccine updates, our clinic here at the health department, we're still open. We're not as busy as we've been, but we're kind of still seeing a steady stream of people coming in, particularly for boosters. So we're open Monday through Thursday and our hours are right up here. And then I kind of put some notes here about who's eligible for vaccines. We know at this point, really Pfizer and Moderna are the ones being recommended for our primary series of 2 doses. Folks can come back. If folks who are moderately or severely immunocompromised, it's recommended that they get an extra dose, an additional dose of Pfizer and Moderna 28 days after the second dose. And then folks can also come and get boosters. And that time frame has changed a little bit. It used to be that it was recommended for 6 months after your primary series, and that's moved back to 5 months. For those who receive J&J for their primary series, it is recommending that folks do come and get a booster of an mRNA vaccine, so either Pfizer or Moderna, 2 months after they've received their J&J. And I threw some of the ages on there too. At this point, our 5 to 11-year-olds are not yet eligible for boosters, but hopefully that will come with time. And we were optimistic that we might see movement around our 6 months to 4-year-olds starting to be able to get vaccinated soon. As you know, there was a little bit of a halt put on that just related to the FDA wanting some more data around whether 2 doses or 3 doses are going to make the most sense for this group to get a good immune response. So with a 4-year-old myself, I am anxiously awaiting the day that he can get vaccinated. Okay, so I wanted to talk a little bit also about some of the isolation and quarantine updates. There have been a couple of pages from the CDC that were updated about 2 weeks ago. So I'll be sure to put those links into the chat just for people to have all that guidance like at your disposal. Basically, as we think about congregate living settings, some of the changes that were made to the general public around like shortened isolation time or shortened quarantine time don't necessarily apply in congregate living settings. As we know, this is considered a little bit of a higher risk type of setting where there's more chance for spread. And so I'm going to try to highlight like some of those differences here. So with isolation, anyone who tests positive, right? We isolate when we're positive, we quarantine when we've been exposed. So anyone who's tested positive, staff and clients should isolate for 10 days from symptom onset or the positive test being collected. And that day is considered day 0. So like the day after that, you start counting as day 1. We at Public Health, through a lot of conversation with a lot of you and with the state and ourselves, have decided relatively recently that we are okay with a shortened isolation time, shortened down to the 7-day option with a negative test on or after day 5. When someone's tested positive for COVID, you don't really want to do a repeat PCR because we know that people might continue to have a PCR positive for weeks or months, sometimes even long after they're infectious. So if we're going to do a test on or after day 5, it's recommended that it's actually an antigen test. Antigen tests are going to measure better whether someone is like acutely infectious. And so it is kind of a good way to tell whether someone's viral load has likely gone down enough that they're no longer infectious, and we would be okay with them coming off after day 5. We really only want to do this shortened isolation time for extenuating circumstances, like in the cases of crisis staffing, right, where you really need staff to come back to work, or if there's a lack of isolation space, we've got clients threatening to leave a shelter or the facility, things like that. And really our preference is that you're talking through that with us and our outbreak team to kind of help make those decisions together and be sure that we're all on the same page. So the other point I wanted to raise is that staff and clients can follow the general population guidance around ending isolation a little earlier for other community settings outside the congregate living settings. So this can be a little bit confusing. Say you have a child in a shelter who is wanting to go back to school, and the school is okay with them coming back after 5 days. Per the guidance for the shelter, they need to keep isolating for a little bit longer, but it is okay for them to go back to school. And then just once they get back to the shelter facility, they have to keep up those isolation behaviors. So this might make sense for staff who are home, not coming to work at the shelter, but they can go to the grocery store and things like that. Or if we've got clients staying at the shelter who have a workplace offsite, it would be okay for them to maybe return to that work a little sooner. But then when they come back to the shelter at the end of the day, they want to keep kind of isolating in their separate area. So happy to answer questions about that. It's a little bit confusing, but I wanted to just give space to talk through it. Guidance is pretty similar for quarantining. So again, clients and staff should quarantine for 10 days. And this is actually regardless of the vaccination or booster status. So we know that people out in the community, if you've gotten all the vaccine you can, if you're eligible for a booster and you've been boosted, you don't have to quarantine after an exposure, but that is not the case for our congregate living facilities. So again, one of those little differences that I want to be sure to point out. Again, we're okay with a shortened quarantine time, like a 7-day quarantine time with a negative test on or after day 5 for those extenuating circumstances that I mentioned. So quarantine folks who have been exposed should plan to get tested on day 5 or after, not earlier than day 5, to figure out if they maybe in fact are going to test positive. And then again, folks can follow the general population guidance, like a 5-day quarantine period, or no quarantine if they're up to date on vaccines, or if they've been positive within the past 90 days, the guidance is that you don't have to quarantine after an exposure for those other community settings. All right, so thinking about testing, who should get tested? At this point, people who have symptoms, people who have come into close contact with someone, like I just mentioned, not earlier than day 5. New clients upon entry to a facility. I think if we're able to do that, we know that it helps to prevent exposures of people coming in who might be bringing COVID into a facility. So I think that's good practice whenever we're able to do it. And then of course, clients and staff at periodic intervals, depending on whether you're in an outbreak, you may be testing weekly, or if not, you may be opting to do some kind of regular surveillance testing. I know I've worked with a lot of you around that. We want to remember not to test individuals who have tested positive within the past 90 days, like I mentioned, because they might have those continued positive results coming in from still having like some dead virus or a really low viral load in their body. As long as they don't develop new symptoms, the guidance is that if someone does develop new symptoms and it seems really clear that they're sick, we do want to go ahead and test them again. And again, an antigen test might actually be a better test than a PCR in those cases. So in terms of testing availability, these are our current sites that are open. We've opened up a couple of new sites with Omicron, and some of those are going to be starting to slow down in the next couple of weeks. So keep an eye on our webpage and our social media for those updates. I've got our website here as well as the testing place website on the state's website. And then, of course, we are continuing to keep a supply of rapid tests for those facilities. Many of you who have a CLIA waiver certificate, that's a process you can go through with DHHS, and we're continuing to try our best to keep a supply of those rapid tests in-house to pass to you. And that is about all I have. So I'm going to stop sharing my screen and happy to answer any questions. I think I see one or two in the chat. So maybe I'll start there. Sharita, am I saying your first name right?
Yes, that's right, Sharita.
Yes, ma'am.
Go ahead, Sharita.
I put my questions in there just because I didn't want to forget my questions. So they're there.
That's good. I appreciate, Russell, what you were saying earlier about all of our competing priorities and like our brain doesn't have enough space to keep it all straight. That's like the story of my life. So yeah, that's good, Sharita. The difference between a PCR and an antigen test, they basically are just looking at different things. An antigen test is going to, it's a little bit, it can be a little bit less accurate. There can be a little bit more of a chance of false negatives with an antigen test. If you get a positive on an antigen, you can trust it. Like you should, it's the likelihood of false positives on antigen tests are pretty low. But sometimes it's easier to get a false negative. The nice things about antigen tests is that they tend to be the rapid tests. There you get the result more quickly as opposed to the PCR, which can take a couple days. And they're basically measuring different parts of the virus, for lack of a better term, parts of the virus and the immune response to the virus. The PCR test is actually looking for pieces of the viral DNA. And the antigen test is more looking at some of the immune response that your body is having to having caught the virus, if that makes sense. I'll put there's a cool website on the CDC that I've looked at more than once that talks about the difference between the two types of tests. So when I get done rambling, I will put that site on there for you.
Can I follow up to that question?
Sure, yeah.
So is the test still collected in the same manner? It's just testing for a different thing?
Pretty much. At this point, we're doing mostly anterior nasal swabs, which are the swabs that are kind of just in the bottom part of your nose, not having to go back and poke your brain like people often talk about with the nasopharyngeal swabs. So yeah, they're pretty much collected in the same way. It's just kind of trying to pick up different things as part of the testing modality. And I see your second question, if a person that is in the 5 to 7 day timeline, where should they be going to get the antigen test? That's a great question. So some of our homeless service providers, you all should have antigen tests there at your disposal, which is great. And then many of our testing sites do give an option for doing a rapid or an antigen test and or a PCR test. So when someone is seeking testing, they could ask specifically for an antigen test or a rapid test.
Okay, Liz, I had a question I had wrote down too.
Sure.
So you were saying that if you have your boosted up, you have both your shots and you're boosted up, but you catch COVID and you don't have to quarantine at all? But you do if you're in the workforce, or is that just, you said at the shelter you have to?
Yeah, let me go over that part again. So anyone who catches COVID has to isolate. Doesn't matter if you are vaccinated or boosted, or if it doesn't matter. If you test positive, you have to isolate. if you've been exposed to COVID in the general public, if you have gotten all the vaccine that you're eligible for, so if you're eligible for a booster and you've gotten it, you've gotten all the vaccine you can. In the general public, you don't have to quarantine. That's the guidance right now, unless you start feeling sick. If you start having symptoms, then you should stay home and get tested as soon as you can. In congregate living facilities, the guidance is still that if you're exposed to COVID, you're around someone who has COVID, regardless of your vaccination status, you need to quarantine. So again, it's like that extra layer of being a little more cautious for people who were exposed to COVID, might end up catching it. We want them to stay out of this slightly higher risk setting until they're able to quarantine for a few days and get tested, and ideally test negative and be able to come back. Does that make sense?
Yes, thank you.
Okay.
Are there any other questions for Liz at this moment from anyone?
Liz, this is Ryan Furman. I had seen somewhere where the 5-day period for folks that are in non-congregate settings, that roughly 20 to 25% of those folks are actually still contagious. And my understanding was that there was pretty specific guidance that make sure you wear a mask if you're coming back in 5 days. So I just want to clarify that, because a lot of the mask mandates are disappearing, and I'd love to get your perspective on that.
I'm so glad you brought that up, Ryan. Thank you for pointing that out. I didn't put that explicitly on the slides I shared, but you are 100% right. So if you're coming off of isolation or quarantine at that 5-day point, or even, if we're making an exception for someone to come off in a shelter setting at 7 days, you do want to be like 100% masking whenever you're around people through the end of 10 days, right? So maybe you're able to go back to work, you're able to go back to school, you can do your thing, but we know that there is still this chance that you might be contagious, or you might not have, had COVID show up yet in your body from being exposed, and you should be masking 100% of the time through day 10. So yeah, thank you for pointing that out.
I want to ask a quick unrelated follow-up and just open-ended question of, as a public health professional, one, thank you for being here. And two, what's your biggest concern at this point in the pandemic?
I think that my biggest concern is I think I have two things that don't necessarily keep me awake at night, but are on my mind. Getting our littlest kids vaccinated. I think that is huge, because we know that so much of the spread that we saw with Omicron was among our little ones in daycare and in schools. And so that vaccines coming on board for them is going to be just hugely helpful to us kind of moving past the stage that we've been in with the pandemic. So I think that is huge. And then I think the other thing that is on my mind and is on other people's minds is just, what variants might come down the road and how we respond to them. And I think that we have learned from Omicron that we had to respond a little bit differently to Omicron than we did to Delta and we did to Alpha. Like each variant kind of has its own dance, its own kind of flavor of what's happening with it. And with Omicron, we saw people getting sick much faster. We saw people getting less sick, like less symptomatic. And so we had to kind of take that information in as we were learning it and tune our response to meet that. And so I think moving forward, we know we're going to have more variants to COVID. We totally expect that. And I think it's going to be interesting and challenging to continue to shift our response and our mitigation strategies to meet whatever variant and like specific characteristics of that variant that might come. Does that make sense?
Liz, while you're right there, I just have a follow-up question.
Sure.
In line with that. So 2 things. I've heard some mumblings about a Omicron subvariant,
Omicron 2,
whatever it is.
Oh.
So I've heard just some little rumblings about that. It's in North Carolina. UNC had 3 cases, things like that. And what I've noticed, so I'm a healthcare professional, and our clinic is in the shelter. So, so at this point, somebody in my household is getting tested for COVID every week. If it's not me, it's my high schooler, or it's my 16-month-old because she goes to daycare, and folks are getting sick. We had this episode in near the end of December, beginning of January, where you could not get a COVID test.
Yeah.
And that terrifies me in light of the just a little kind of mention of the subvariants. The notice that I'm having of when I go for the weekly test now, how few people are in the lines, whereas before it was like tons of us pushing for space, and now how you kind of walk in the door, get what you need, and walk out, and it's not really long of a wait at all. How, I don't know. Do you foresee us changing, at least at our public health department site, us changing or reducing significantly anytime soon our access to testing?
Yeah, I think, Sharita, I feel like you were a fly on the wall with a planning meeting that we were having yesterday here internally, because that point came up. I think when Omicron was coming, we knew it was coming, and we didn't know how quickly it was going to just really blow anything that we had ever seen before, like out of the water, in terms of the number of cases that were coming in every day and the demand for testing that we saw. So one thing that we are talking about on a really pretty granular level is like, what are the testing sites that we have? How can we be sure that they continue to be, even if they slow down, or some of them do, like I mentioned, do close down in the next couple of weeks, how can we be prepared to like open them right back up if that need for testing increases again? I think that's a lesson learned from Omicron. And I feel like you were sitting in a meeting we were having yesterday about that exact point. Sheldon, I saw your hand up.
Yes, I wanted to ask, so in terms of like the guidance around the social distancing and capacity and congregate, do you have any ideas in your discussions about the time frame that we will continue to fall under those measures? Sheldon,
you know that you're going to be the first person I call whenever I do have any information about that. So no, we don't. I know there's been, and I'm sure everyone is aware that there's been discussion, among the county commissioners and the mayor and others around like our mask mandate and kind of our local ordinances, and social distancing, I think has been a part of that discussion, but at this point there isn't really anything clear coming really from the state or the CDC and here at the local level around like when social distancing requirements might be lifted. But it is definitely, I would say it's in my top 10 priorities, Russell, to think about like when that's going to be possible, because I know it has really concrete kind of ramifications for what y'all are able to do in the congregate shelters. So I think it'll come, but I don't know when. Yeah.
Thank you.
Yeah. Russell, I see your hand up.
Thank you. And just a quick question. I think I have a vantage point since I don't operate a shelter to ask this question, but my understanding is that we have pretty low vaccination rates among the community of folks that are experiencing homelessness. And I guess I'm just curious, now this is a question for the group for down the road, is how we'll navigate an individual's right to make that decision with the need to be protecting staff of the shelters, partners that come in. And I don't know if if there's a point where there's a discussion on what a framework for making such a decision would be and balancing that going forward, but I'm a step removed from it to some extent. I mean, our staff do engage very closely with shelter folks that are in the shelter, but without operating a shelter, it's not quite as pressing for us, but just curious how we may broach that at some point as things start to change, or we kind of try and get into whatever a new normal may look like for a period.
Yeah, Russell, I feel like that has it been a question that I know I've heard come up in lots of our discussions, even when we were initially starting to think about how to get vaccines out to folks experiencing homelessness. And I think it's still a question, you know, as it relates to primary vaccination series, as it relates to boosters. Yeah, I think that's a super applicable question to kind of grapple with.
Are there any other questions for Liz at this moment from anyone in the audience? Okay, well, Liz, I guess it's not, and thank you very much for presenting this information for us. Thank you so much.
You're welcome. I'm going to put a few links in the chat here, and I'll also put my contact info for those of you who don't have it. So feel free to reach out anytime. And our power is back on, so that means my phone works.
Okay. Well, thank you so much. Okay, we're going to be moving along now. We're we have switched it up a little bit. We're going to go right along with policy and planning for the presentation on emergency needs for the COC, including the non-congregate and expanded services due to COVID. And at this moment, I'm gonna call for Sharita and Colin. Are you ready?
Yes, I'm ready. I'm gonna kick it off, and then I'm gonna send it over to Colin to present some data, and then we will answer questions. I do apologize that my camera's not on. I'm having some technical issues here, so I'm just gonna leave it alone so you can hear me. So as we discussed last month, the Policy and Planning Subcommittee will be presenting today to HSAC funding recommendations for to support the ongoing and future opportunities for the continuum. Our plan with the guidance of the community development staff was to convene a group of all interested persons to help us shape and make a coordinated ask of our elected officials as it relates to the needs of our system. As with many things since the onset of the pandemic, time went by and we were not able to convene that group of persons to talk about the needs. As a result of this, today we are making a one part of a two-part recommendation in the spirit of urgency to be able to maintain what we currently have in place. Considering being in a pandemic and seeing our federal funding streams dry up at the end of the fiscal year, June 30th, the funds that we have that are currently supporting our Well Hotel and our respite and White Flag initiatives will be ending soon. And we recognize that puts us in a very complicated space with the pandemic, which requires us to try to make sure first that we keep our residents safe and sheltered, and especially while we still have social distancing and mask requirements in place. So today we are putting forth a recommendation for that first part to sustain our current well and vulnerable hotel shelter space and the supportive services that have been included with that. But I want to add it is imperative that we prepare that second part of our ask, because we have some special opportunities to use some one-time funding to do some real investments in our system. So please stay tuned for updates and requests to convene or requests for recommendations for things that you think that our system would benefit from in the very near future. And with that, I will turn it over to Colin.
Thank you, Sharita. The Policy and Planning Committee received requests for needs that came from a group of providers who are currently meeting exigent needs and had been receiving ESG COVID funds throughout the pandemic. And as you're aware, these ESG COVID funds will be ending, June 30th or shortly thereafter. For the most part, the contracts are written to have all the funds spent by June 30th. The needs, however, seem to not necessarily be going away. And while we don't have any guidance from FEMA as to when non-congregate shelter waivers will end, we also know that mask mandates are ending, but we don't know if mask mandates ending will translate into social distancing guidelines ending. And as you know, going back to a congregate shelter is impossible while we've got social distancing guidelines in place. And I'll say it's not impossible to go back. It's just one of those things that increases risk of infection and outbreaks. So the policy and planning wrestled with sort of a three-phase approach of what to fund and needing to what we need to do to meet the urgent needs, i.e. within the next 12 months from July 1, 2022 to June 30th, 2023, or if social distancing guidelines end sooner than that, what would we need to do to get that through? The second wave of the request is kind of expansions of items in the continuum of care that are currently operated. And that needs to be overlaid with some other things that are on another list. And the third request that came from the group was kind of capital improvements or capital investments in projects. So given that we had three different things and given our time constraints, policy and planning focused on the exigent and factored we would take the next steps and logically work our way through the next piece. So I'm going to share my screen and kind of walk you through where we are. And I may ask Russ, Sheldon, and others who are part of that committee to help fill in or answer questions if they come up, if I can't answer them. So let me walk you through this. All right. So right now, the current COVID related need is this non-congregate shelter. Currently, we're renting 64 rooms at Carolina Duke Inn. This does not mean we have to rent at Carolina Duke Inn. This could go anywhere, but that's currently where it is, and about $1.9 million per year to house people who are medically fragile with disabling conditions or high risk for negative outcomes if they were to test positive for COVID in a congregate shelter. The second piece of this is while renting the rooms is $1.9 million, we can't just put people in rooms without food, support, transportation, and other things. So this $799,000 request covers the support, the security, the food for people at Carolina Duke Inn. It also includes shelter for people who test positive for COVID and food in shelters that may have shut down kitchens or other congregate areas to provide food due to social distancing guidelines. So that's your big pot there. Questions on this slide? I can't see, so I'm going to need somebody to help me. If questions come up, Angel or Sharita, could you interrupt me if any questions pop up?
Will do.
Okay, thank you. Then we go to the second tier here where we've got other emergency shelter requests. This is kind of tied tangentially to the COVID pandemic, that we stood up a white flag emergency shelter, which included rooms at CDI that are separate from the 64 rooms at CDI. It also includes socially distanced congregate shelter in the basement of Trinity United Methodist Church currently. So this would be, if we have the same guidelines in place come, December 2022 to March of 2023, if we chose to continue a white flag shelter the way we are, this is about what it would cost and helping about 228 households. We then have another issue that our intimate partner service provider raised and brought to our attention that their shelter is currently not being used. One, because of social distancing guidelines, it wasn't feasible to continue using it. Two, there are issues within the building that may not make the building habitable to return to after the COVID pandemic. And the provider has been using state ESG COVID funds to, essentially run our intimate partner violence emergency shelter in various hotels. And the thought was we would need to continue doing hotel cost until we can find a way to return to a appropriate shelter. If the shelter is able to be rehabbed or if it needs to be rebuilt, that's a whole other longer conversation. At this point, these are, about little less than $500,000. And then we have sort of to what Russ was talking about earlier today. And there's three pieces to rapid rehousing. You've got the supportive services and rental assistance. You've got the navigation that helps people get from homelessness into permanent housing. And then you've got the group who goes out and recruits the landlords, incentivizes the landlords. And there are three different pieces, but that total cost and the projection is $959,000 per year. Historically, our landlord engagement, as the landlord engagement piece in this, I believe Russ was 185,000 off the top of my head. Does that sound right? 181, 185?
That sounds correct. I'd have to pull up the presentation again. Check, I can do that.
Sure, yeah, it's in that neighborhood is what the landlord engagement piece is, which had incentives. Historically, landlord engagement in previous years had only been $115,000 per year when it was done by CEF. That would be an increase. This dollar amount is also on top of, and I want to clarify, Russ, this is above the ESG and dedicated housing funds rapid rehousing, correct?
Right, that 185 was an estimate based on the current NCCH grant is 225. And
Okay.
that includes some staffing and the incentives. So this would be some staffing and incentives on that 185. Yeah.
Okay. And then, so you have the 185 for that, and then you've got the rapid rehousing supportive services. The balance of that, roughly 775,000-ish, would be for the other pieces, and that is on top of that's on top of the ESG DHF contract, correct?
Yes.
Okay. So this is
So,
an
Russ,
expansion.
Let me pull it up.
So I have a question.
Mhm.
For you, Russ, and then Colin. I attempted to answer some of your questions in the chat. So if you get a moment to look,
Sure.
if I said something in error, you can correct it. So Russ, you gave us a presentation in the beginning. I'm doing our open forum
Yep.
time. That's not what it's called. Is this screen that we're looking at now kind of part of that, or is this a different whole pot?
So I think the way that Colin has constructed it, that work and those incentives are represented inside this. Yes.
They are.
Yeah.
They're in that.
In the presentation, planning and policy saw it was broken out, I think, into 3 places, and he's rolled it up together. And I think there's even some other rapid. It's not just H&H rapid rehousing in there. I don't think. I'll try and get the other presentation open.
Yeah, I was trying to roll it up to make it a little bit easier to follow and trying to total it up. So this is, and the reason I'm bringing up the rapid rehousing, because the rapid rehousing is important. And as Russ highlighted, the last time we had to shut down a motel, we were able to move a lot of people into permanent housing so they didn't have to go back to congregate shelter. So it's kind of important to have these pieces in place. That's why it kind of falls in this exigent needs piece. Now we go to our next piece. Let me see here, hold on. And I did see, there was a question, Drew, the FEMA costs would only cover, yeah, they would cover some of the cost. FEMA would not be eligible to cover rapid rehousing. FEMA would cover non-congregate shelters. So the renting a hotel, FEMA could possibly be reimbursed for food and laundry, but FEMA will not reimburse any supportive services, to my understanding. We'd have to get clarification on that, but that was one of the pieces that sort of makes this an interesting split between the city and county, because currently the county is using FEMA dollars or could seek reimbursement from FEMA. And as Drew said, you do have to advance the money and then get reimbursed at some later date by FEMA for that.
Okay, Leah has a question in the chat, Colin, for you.
Clarify, would this amount allow to maintain housing connections, landlord engagement work funded by the public? Yes, this would allow sort of a continuation of that program. There may be a gap in funding for a bit if the current funding ended May 1st or May 31st, and this funding might not be able to start till July 1st, because one, we have to figure out, is there money available? How much money is available? And then how long is the money going to be available? Because, you know, as you'll see later, we have a whole lot of long-term needs or requests that have been brought to the system. And we as a HSAC and policy and planning have to go through and say, okay, if we do this for a year, we're going to have another fiscal cliff a year from now. And that's not fair to Housing for New Hope. It's not, and it's definitely not fair to clients. But by the same token, if we commit this, it may mean other things in the system may need to be put on hold or not funded for a variety of reasons until additional funds could be found. So yes, there could be a funding gap depending on the time it takes to do the art, because we're going to have to do an RFP to get these funds into contracts. All of that takes time. So there may be a small funding gap, and there might be a way to bridge that gap, but without doing some research, I'm hesitant to commit anything without some due diligence on it. So to sum up those previous slides, the request is for 4.1 million. 2.7 million is going to the rental of a hotel, renting hotel rooms, and supporting guests in those rooms, and food in other places. Then you have a $478,000 request to take care of intimate partner violence for a year, and white flag, should we choose to endorse this plan, and the $959,000 request for continuing the expanded rapid rehousing, housing navigation, and landlord engagement system. The caveats that we need to be aware of is $4 million per year may not be a sustainable forever dollar amount. And even if it is a sustainable forever dollar amount, are we able to find more money for some of the things we're going to talk about in a little bit, or are we going to have to at some point possibly wind down or reallocate some of these funds to other things if there are things that we need to do in the system? These are things just to think about. And as the HSAC is taking on the advocacy and advising piece, it's thinking through and just being aware of the pieces that are out there. The other piece, non-congregate shelter and other funding could be tied to social distancing guidelines and FEMA reimbursement. So if we scale down, if FEMA stops reimbursing hotel, motel, non-congregate expenses, that portion and everything tied to FEMA support may be wound down prior to a 12-month end of the year contract, depending on how things are set up. Questions?
The other concern that I think that would also be a challenge in this request. You know, definitely the sustainability of this amount forever, but also just thinking about our inventory issues, thinking about, I think every week we get an update on how expensive it is to live in North Carolina. 30% increase, I think, was the last story that I just seen in rents. And a lot of our funding programs, the rate that, you know, if there are any increases in how much a rent could be, is still not matching that. And so, you know, I think we can have landlord engagement, we can have incentive plans, but if we can't get rents down to, you know, one that our short-term programs can pay for, and then our people can sustain after the funding goes away, we also need to be looking at that. And so it makes me think that we need to be turning our attention to trying to increase our inventory on our own, with a lot of additional things to go along with that, because we are also seeing revolving doors. We're housing people and they're staying for a little while and they're coming out. So you know, that's a real concern as well.
So, okay. So now we're going to go, so future planning. So we've got this current $4 million request. And here's a list of other things that has just been started based on what we've been hearing from people over the last year or so of wants and needs in the community that we need to sort of flush out, add dollars to, and prioritize. So we've taken the approach of breaking this up into funding categories. So this is related to emergency shelter and unsheltered people and how we can help them. So this is permanent medical respite, permanent white flag program, permanent non-congregate shelter, or a redevelopment of shelters, a day shelter, shelter for couples without children, harm reduction shelter, a permanent intimate partner violence shelter, and an additional street outreach capacity. So these are things, some of these you notice intersect with the short-term requests, and medical respite is included to a degree in that first exigent request, because there are people coming out of hotels, motels that need that are not going to a congregate shelter, they're going to a motel and receiving care there. Then we loop in permanent housing requests that also need funding and attention. So additional supportive services for people who are in permanent supportive housing, rapid rehousing, or have housing choice vouchers, new construction of supportive housing units, additional diversion prevention services, landlord engagement, recruitment management, that's on the list up above. DHA, DHA has a homeless priority that they need to implement. Additional permanent supportive housing slots, which includes rents and supportive services. More money for rapid rehousing slots, which goes to that first request. Skinny subsidies for those moving on with vouchers and unmet financial assistance needs. And a home repair program for landlords committing to renting to people experiencing homelessness. And then we get into the supportive services. So there's been requests and identified wants for SOAR workers, capacity building for helping improve low barrier shelter, capacity building for small and new homeless service providers. So we've got providers in the community who right now are unable to compete for federal dollars due to the way they're structured or the inability to use reimbursable contracts. So that would be helping additional providers come online. Homeless liaison position to work with DHA on issues. Planning funds for redevelopment and new construction. And then some data regarding public facing dashboard, data warehouse, things along those lines. Let's see, hold on, look at this. Yeah, and I'm seeing sex offender housing, transitional age youth shelter. These are things that this is not an exhaustive list of wants and needs in the community. This is a starting list of things that have been brought to attention. And by all means, we'll add, youth shelter, and we'll need some help and guidance on that. I think that was you, Shaisha. But I will add that to the list to keep it on the radar. Thank you for bringing that up. So next steps for future planning, we have to determine costs, number of people to benefit from all these proposed needs. We need some data analysis, needs and gaps analysis, prioritize all the needs, propose options and cost, figure out funding from a variety of sources, because it's not a guarantee that city and county are going to be able to cover 100% of every want and or need in the system. So this could easily be $6 to $10 million per year, depending on how involved and how big you want it to be, and whether that's a in perpetuity sustainable number from county and city sources alone, I don't know. Any public money would require RFPs, contracts, and then works. And this is going to take time. This isn't something that happens overnight. And we can start some of it, but we also need to make sure that we don't end up having to redo all of the work, because in order for us to access the $4.3 million of home ARP funds, we're going to need to do needs analysis, gaps analysis, and a whole lot of work. And if we start it now, we just need to make sure it lines up with what the home ARP is going to require, so we don't have to go back and redo all of the same work. We don't have capacity to do it. And we are looking at bringing in a consultant sometime later this year. The home ARP funds have a longer spending timeline, and ESG, COVID, and these exigent needs seem to be consuming most of our bandwidth at this point. Next steps for exigent need. At this point, to meet the first 3 or 4 slides in there, the request would be HSAC making a determination today to support or modify, and then make a recommendation to fund some or all of the total request, that $4.1 million, to city and county leadership, depending on how the HSAC chooses to vote. A letter would be sent by our chair to, appropriate city and county leadership. City and county would have to then figure out how much funding is available. City and county may have to do, well, I know the city will have to do RFPs. I don't know if the county will need to or not. So Drew could answer that. For contracts, city and county would have to complete contracts and then work beginning on or about July 1st. So it's a little bit of a process. And questions?
So Colin, I have a quick one. Are the youth going to be added to this list right here?
They are not currently in the exigent list. Is there an exigent youth need that has a concrete dollar amount?
I wouldn't know.
Yeah, I don't know the answer to that question either.
Yeah.
It's not currently on the exigent need list.
Okay.
But if there is a cliff need that's documented, if it's a youth specific request to be sort of looked at in the future planning, that'll definitely be added to that list of items.
Okay, because it was 2 questions in the chat about.
Yeah, so sex offender housing and
I just think Shaisha and Colleen Herbert both noted that they were surprised to not see anything mentioned about youth on that list that you had. I think that's what she's referring to.
yeah. And like I said, this was just the list of items that had been brought to my attention kind of over the years. And I was trying to do it from memory, and I totally spaced on the youth housing because I didn't have a concrete piece, but I will add youth housing needs to the list. And we'll just need to get some clarification on how do we operationalize youth housing needs.
The other thing, Colin, that I'll add is that the Policy and Planning Committee has asked me to put together a survey to help get community feedback on priorities. And there will definitely be a section in the survey for people to write in additional items that we left off. So that'll be another opportunity for anyone who sees something that we missed to share. And if we see a lot of people sharing something similar that we missed, that's a good indication that it's something the community wants to think about.
Tracy and Miss Washington, Janice. So go ahead, Tracy.
Yes, thanks, Colin, for sharing that information. Are your numbers projected on past trends, or what you're projecting what the need is based on where we are right now?
The projections for the 4.1 million.
Yes.
The 4.1 million was based upon what would it cost to continue doing exactly what we're doing without increasing services, because it was, and then there was a separate chart of if we really wanted to make a bigger increase, we would need to invest more than that. This is just to maintain what we've been doing for the last basically 2 years, where we've had additional money coming into the system.
Because I wanted to clarify because if the cost of housing is increasing, which is constant, but the services stays flat, I'm just wondering, how do you project the amount that you will need moving forward? Is that number pretty accurate in terms of what you'll need to move forward?
That's a good question. I think part of the challenge is we have to marry what we're doing with these funds with what we're doing with federal rapid rehousing funds and some of the other federal funds that have, fair market rent guidelines that have to be adhered to. So, while housing prices are going up, it limits what we can do with our federal dollars to get people into housing, because we can't go above the fair market rent without triggering problems with HUD. So we could put all the money in the world, and that goes to Sharita's point, was, we've got a diminishing supply of housing units that meet HUD's fair market rent standards. So we could put all the incentives in the world in there to incentivize a $2,000 a month unit. Problem is, we can't spend a penny of federal money in that unit because it's over the fair market rent.
And if I can add, Colin, just an additional clarification, we're not saying that this is what we need to serve everyone in the homeless system that we believe needs housing. This is only what the providers have told us it would take to sustain what we were funding with our federal funds that came in. So this is not an attempt to estimate what it would really cost. That would be a very, very different number. So I just wanted to clarify that.
Janice.
Hi, yes, forgive me for if this is probably understood amongst everyone else and not myself, then I'm new here. So is there a criteria or a metric that is used to determine what makes it to the exigent list?
Yes, we were looking at, what we had to do was figure out what essentially is falling off the cliff July 1st. And if that goes away, what is the alternative? So for instance, if we have social distancing guidelines still in place July 1st and no funding in place to continue non-congregate shelter and operating that, we will have roughly 65 to 75 people who are currently staying in a hotel immediately return to unsheltered homelessness. And it was that's not really a palatable solution. Is it something we could do? Absolutely. Is it the right thing to do? Probably not, if you've got a pandemic still going on and social distancing guidelines in place. And, other jurisdictions have returned to non-socially distanced congregate shelters, and they've had some pretty big outbreaks and needed to start moving people out while they're sick into places and having to go back and try and get exigent hotel rental costs. And Durham has been very fortunate over this pandemic, and Liz might be able to speak better to it than I can, but statistically speaking, our positivity rate in the homeless system has been pretty low. And I think a lot of that is due to our socially distanced shelter and our use of non-congregate shelters since day one. And we've really, really kept that, percentage of people testing positive very low.
Thank you for that.
You're welcome. Other thoughts or questions?
Colin, can I just add one other factor I think that is worth, crediting all of us with is I do think that we've also done a good job of testing, right? And of really working hard to try to identify when we've had positive cases and identify close contacts. And I mean, it's not been easy, but trying as well as we can to isolate and quarantine people. So I do think that it hasn't been perfect, but it has been significant. And I think it has really helped. And I give kudos to the providers, the homeless service providers for that.
Thank you, Liz. Very true.
Thank you, Liz. Anyone else have any questions for Colin at this moment? Or Sharita, or at this moment?
There's no other questions, Madam Chair. You could ask for a motion if you would like one to either, to do whatever somebody would like to put forth a motion to do.
Yeah, well, can we have a motion to adopt this plan right here? Can I get a motion? Yeah.
The motion would be to approve or to ask HSAC to request or endorse the $4.1 million request to city and county officials to try and secure funding. To continue operations during the pandemic. Something along those lines is what the motion would look like. We're not looking at endorsing everything under the sun, just that original $4.1 million for non-congregate shelter, white flag, intimate partner violence, and continued the expanded rapid rehousing with housing navigation, landlord engagement, to the extent that it's feasible.
Colin, for my thinking, could you just put that one slide back up, because that's what we're going to be voting on, just that one slide. Sure. I know we talked about a lot after that, quite a bit after that was not related.
Thank you, Colleen.
Yes, ma'am, I can do that for you.
Thanks.
Find it. This slide.
Is that the one, Colleen?
Trying to hit my unmute button. Yes, just that one, because I think that is the vote. All of the other was just discussion. This is.
It was. Yes, you're correct. This is sort of what the vote would be on. The rest of it is just to be aware that the biggest concern is obviously non-congregate shelter. When that funding is no longer needed, we would essentially just go back to congregate shelter and those expenses would no longer be there. White flag may go back to pre-COVID white flag days, not the expanded white flag we've been doing potentially. And the bigger question would be if white flag continued and expanded rapid rehousing, that's essentially $1.2 million. And if we had to do the non-congregate intimate partner violence, you're at $1.4 million, $1.5 million. And whether or not that dollar amount, how long that dollar amount would be sustainable. And if it is sustainable, would it create problems later on in our funding cycles? And being able to take on some of those other lists, such as the youth housing needs, SOAR workers, and the lists that follow after this. But in the short term, this would be the request for a 1-year funding, and then everybody would just know this is guaranteed 1 year. And it may be substantially less in year 2, which would be July 1, 2023.
But we
But this
don't
is-
know if it would be guaranteed. We would be hopeful that we would have it. Is that correct? It wouldn't automatically be like we ask for it, we get it.
Correct. I mean, the HSAC can ask for $4.1 million. The city and county may say, you know what, we have 3 million, we don't have 4. The city and county may say, sure, we have 4.5. We don't know what's going to happen, but that's where the HSAC needs to, this is what the request was 4.1 million to continue operating as is that we've been doing during the pandemic. And then obviously policy and planning, HSAC will be working on prioritizing and working through, funding requests for a longer term substantial, investment long-term based on that list of items that followed this.
Madam Chair, this is Helen. I'd like to make a motion for the HSAC to support the 4.1 million for the exigent needs.
Okay, thank you, Helen. Can I get a second motion, please, from someone?
Shay Kanar was second.
Thank you, Shay. Maybe we could vote on this in the chat. Okay, Dr. Birch, does it look like everyone, it does pass?
Yes, I'm counting now.
Thank you, sir.
Yes, it looks like you have a majority.
All right, thank you so much.
Sure. We will, we'll get you a letter and you can submit it to request to city and county leadership. And
Okay.
I'll work with you on that.
All right, thank you, appreciate. So we're finished, we're moving right along to the announcements, and I would like to reintroduce our City Councilman Mark Anthony Middleton has just joined us. Sir, can you hear us?
I can, Madam Chair. Can you hear me?
Yes, sir. Go ahead.
Very briefly,
Yes.
it is so good to see you holding the gavel. We are in hands, and just want to reintroduce myself quickly, reintroduce myself to some people. So see so many great friends and just great fighters for the people of our city on the screen. So I'm going to be rejoining the ranks. Some of you may remember that under Mayor Schul, I was Mayor Schul's alternate to this commission, and then special assistant to the mayor, Amber Wade, who's done a fantastic job, started coming. But we had another election just a few months ago, and in her honor, Mayor O'Neill sends her regards to all of you and thanks you for the incredible work, the important, vital work that the council does. She's asked me as Mayor Pro Tem to attend these meetings again personally, and hopes that that will convey just how important we think this work is. The mayor and I both share the belief that the greatest measure of Durham cannot be taken without considering how the most vulnerable amongst us fare. So this is absolutely critical work. So it's good to be back. Looking forward to the work. I did not vote on the ask because I'll be one of the people considering that ask coming before the city council. But I can tell you, I think we're moving in the right direction. So thank you, Madam Chair. Good to see you all. Looking forward to the work ahead.
All righty, thank you. Okay, if there are any other announcements that need to be made right now at this moment, before we.
Can I make an announcement?
Sure, go ahead, Sharita.
Hi, you guys hear my voice again today. You might be tired of hearing it, but nonetheless, you got me. at least for now. I just want to make an appeal. Doing this work is, I do it every day. I don't just come to the HSAC from some other job and I'm far removed. So I see the needs. I serve the people. I navigate the challenges with folks every day. And I say that to say that a lot of great work can happen within the walls of the HSAC. But in order for us to do that, it requires folks to participate. It is not just, our subcommittees are not just open to the membership. They are open to the community and the continuum at large. A lot of important work can get done within the walls of HSAC. But we need you. We need folks to be present. We need folks to be informing us. We need folks to be telling us what they need, so that when we come to moments where we have to come up with plans about wish list and things that we really need to make radical shifts and changes in the city of Durham for folks without homes, we are well informed and we can do that without it being pressured, without somebody having to send us a survey. We know what's going on. So this is an appeal for every person in the sound of my voice and other people you may have sitting in desks that want to participate. Please come to the meetings. Please talk to us. Please partner with us. Please work with us. We want to get it right. We want Durham to be the best it can be for all people. If we can serve the people with the least, it's no limits or bounds what we can do with folks that have more than that. So please, please, please consider joining us. Go to the Durham COC website, see when our meetings are. The videos are there, the minutes are there. Read, catch up, send us messages. We are very easy to engage people. Please, please, please consider participating. Thank you.
Leah,
Okay,
yes, committee meetings are open to the public, so people are anybody's welcome to attend committee meetings. And we'd love to have as many people coming to those meetings as possible, because the more voices we have in those meetings, the more work can be done and end up with better outcomes.
Yes, everyone share their opinions on how or what they think can help as far as this great work is trying to end homelessness here in Durham. Okay, so with all that being said, does anyone else have a dire need to express anything that's within on your heart, soul? So with that being said, I ask for a motion to adjourn the meeting. Everybody left.
So moved. Since no one wants to do it, I'll go ahead, Madam Chair.
Thank you, sir. I greatly appreciate you. Can I get a second? Someone?
Second. This is Renee Vaughn, second.
Thank you, Renee. I appreciate you. Okay, so with those two being said, I guess we are adjourned right now. For those who are still woke. God bless. See y'all at the next meeting. Have a great day.
Have a great day. Thank you, Madam Chair.
You're welcome.
Madam Chair.
Thank you. Y'all have a great day. Bye.